Nutraceutical supplements for headache. Headache is an exceedingly common problem. Probably the majority of us have all had at least one headache in our lifetime. Many people seek ways to treat and prevent headaches, and many of them are seeking non-prescription ways to do that. The primary focus of this program is on migraine headaches because that's where the most evidence supporting use of nutraceuticals can be found. We will do a brief overview of the major types of headaches. Then we'll move on to talk about effective supplements and appropriate doses and cautions for primarily migraine headache. As we go along, we will incorporate a patient case. How common are headaches? Well, as I said, they're very common. Just about everyone experiences an acute headache at some time in their life. These occasional headaches are easy to treat with some acetaminophen or a nonsteroidal. For many, headache is a regular, ongoing occurrence that impacts their daily lives. These people have chronic headaches. In fact, over 45 million Americans suffer from chronic headaches. These patients make 80 million visits to their doctors and lose 157 million days of work each year. Headaches are one of the most common reasons a person visits a primary care provider. The International Classification of Headache Disorders, published by the International Headache Society, is used to classify more than 150 types of primary and secondary headache disorders. The listing on this slide is pretty much in order of occurrence. Tension-type headaches are most common, followed by migraine, trigeminal, autonomic, cephalgias, secondary headaches, and some miscellaneous. We'll talk just a little bit about some of these other headaches. Secondary headaches, these are ones that are symptoms of another health disorder. And you can see many of these are listed here. Cervicogenic, that is the cervical spine causing the problem, chronic sinus infections, medication overuse. And we're going to spend some time later talking specifically about medication overuse headaches. Secondary headaches are not the most common types of headaches out there. Trigeminal autonomic cephalgias are primarily disorders of the trigeminal nerve. They include cluster headache, paroxysmal hemicrania, and SUNCT. Cluster headaches, the most common of these. Cluster headaches are sudden, extremely painful headaches that occur in clusters, usually at the same time of the day or night for several weeks. They typically strike one side of the head, often behind or around one eye. Some people even call these suicide headaches. They're very, very painful, and people will do just about anything to try to find relief for them. Cluster headaches occur more often in men than women. Cluster headaches are primarily treated with oxygen therapy and the triptans. Some people do try to use preventative medications, that is daily use of a medication to reduce the frequency of cluster headaches. Antipsychotic drugs, calcium channel blockers, and anticonvulsants have all been used to reduce pain severity and the frequency of attacks. Tension type headache is the most common type of headache. This was previously called muscle contraction headache because in the past we thought that the pain came from muscle contraction. But the International Headache Society intentionally abandoned the terms muscular contraction and tension headache because no research actually supports that muscular contraction is the sole pain etiology. It may be a secondary effect to something else going on that you then end up getting muscle contraction and tightness. Research seems to indicate that patients with tension-type headache may have abnormalities in the central nervous system, which includes the nerves in the brain and spine, that increase their sensitivity to pain. You can see on the slide there are a lot of triggers for tension-type headache. Many people can trace their headaches back to jaw clenching, grinding their teeth at night, stress issues, work issues, etc. Poor ergonomics, where we work all day with the phone trapped between your head and your shoulder, leads to a lot of tension headaches. Tension type headache typically has mild to moderate pain, that feeling of pressure or tightness around the head. It's usually on both sides of the head, in contrast to cluster headaches and migraine headaches, which tend to only be on one side of the head. People can have either episodic or chronic tension type headaches. Episodic is they have fewer than 15 headache days a month. Chronic is considered greater than 15 days per month. Greater than 3 months is the International Headache Society criteria. Most people with chronic tension type headache started out with episodic. Almost all these different headache disorders can have an episodic version and a chronic version. And that if people don't get adequate treatment for their episodic headaches, they can progress or evolve into chronic headaches that then become much more difficult to treat. About 17% of women and almost 6% of men experience migraines, which are one form of vascular headaches. These headaches are characterized by throbbing or pulsating pain. Migraines are less common than tension type headaches. Migraines are typically moderate to severe in pain intensity. The pain is usually unilateral, pulsating, and may be located around the eye on the affected side. Untreated pain can last up to 72 hours in a single migraine. Other common symptoms are increased sensitivity to light, noise, and odors, and nausea and vomiting. Things that make the headache worse are physical activity, movement, even coughing or sneezing. Migraines do occur most frequently in the morning, especially upon waking. Some people have migraines at predictable times, such as during menstruation. A lot of people actually feel exhausted or weak following a migraine, but are usually symptom-free between attacks. There are a tremendous number of triggers for migraines, and many of them are listed here on this slide. And it really varies from person to person what triggers their migraines, and people actually need to figure out what their triggers are and find ways to avoid those triggers. It's like asthma and asthma attacks. If you can figure out what the triggers are and avoid them, you can reduce the frequency. This next slide shows you the pathways of migraine, and this is from the National Headache Foundation. We don't exactly know what causes migraines, but we do understand now a little better the process of this type of headache, in that we think that there's activation of nerve fibers within the wall of the brain blood vessels. The vessels narrow temporarily, which decreases the flow of blood and oxygen to parts of the brain, and this causes other blood vessels to open wider and increase blood flow. We know serotonin's involved, and we also know that the trigeminal nerve is involved. As you can see on this next slide, there are lots of different types of migraine. Migraine with aura previously was called classic migraine. This is where someone has visual disturbances or other neurological symptoms that appear 10 to 60 minutes before the actual headache occurs and usually last no more than an hour. People with aura may temporarily lose part or all of their vision, which can be scary. Other classic symptoms include trouble talking, abnormal sensation or numbness or muscle weakness on one side of the body, tingling sensation in the hands or face, and even confusion. Also, nausea, loss of appetite, increased sensitivity to light, sound, or noise may precede the headache. Migraine without aura, or what used to be called common migraine, is the more frequent form of migraine. Here, the person has headache pain that occurs without warning. Again, it's usually on one side of the head. The chart on this next slide compares the three major types of headaches here: tension like, migraine, and cluster. So if you're trying to help someone, they're I wonder if I have migraines. Well, here are some of the symptoms that are classic for migraine. So if somebody's complaining of a headache that's typically on both sides of the head, that's usually tension-like, one-sided, maybe migraine or cluster. Something that distinguishes cluster headaches from migraines is tearing of the eye, flushing of the face, nasal congestion that occurs on the side of the headache. With cluster headaches, a lot of times pain develops during sleep. Migraines may be once they wake up with a headache, but they're not awoken by the headache. Migraines are more common in women than men. Cluster headaches tend to occur more often in men. Tension-like headaches hits everybody pretty much equally. The web address given here is for a complete comparison chart of various kinds of headaches that goes through what's the most common symptoms of each headache and what are the common treatments, just for extra information. Not all headaches require medical attention, but headaches can signal a more serious disorder that requires prompt medical care. Here's just a listing of some times that we might need to be concerned and suggest that someone seek medical attention. Sudden severe headaches accompanied by stiff neck. The first or worst headache, often with confusion, weakness, double vision. Now that can be a migraine, but it could also be an aneurysm that is getting ready to burst or other things. Headaches that are changing. That's another reason to be seen. If somebody has 2 or more headaches a week, they probably have a chronic headache disorder. And there's probably help for them to reduce their frequency of headaches, so they should be seen. Persistent headaches in someone who's been previously headache-free, particularly someone who's over the age of 50. Most headache disorders begin before age 50, so if somebody has new onset headaches and they're over 50, that suggests an underlying reason. Earlier I'd said we'd talk more about a secondary type of headache, medication overuse headache. This is a chronic headache disorder with daily or near daily symptoms caused by overuse of acute medication. This was previously called rebound headache. Taking headache relief medications more than 3 times a week can lead to medication overuse headache, in which the initial headache is relieved temporarily but reappears as the medication wears off. Then the person takes more of the medication to treat the new headache that leads to progressively shorter periods of pain relief and results in a pattern of recurrent chronic headache. This headache pain ranges from moderate to severe, can occur with nausea or irritability, and it can take weeks for these headaches to end once the medication's stopped. Now, how can we identify medication overuse headache? Someone's having 15 days or more of headache a month. They've been overusing medication. Basically, they've been treating those headaches multiple times for greater than 3 months with 1 or more acute medications. So it can occur with pretty much anything you treat headaches with. The headaches have had to have developed or markedly worsened during medication overuse. So a lot of people think that they have a chronic headache disorder and they keep treating it with medications, but it may actually be the medications leading to headaches. Now, why exactly this occurs, we don't really know. The reported prevalence is about 1% of medication overuse headaches, but it may even be higher than that because these are a little hard to identify. Treatment of a medication overuse headache is not using medication to treat the headache, and it is very hard. It really means tapering off that overused medication, possibly while overlapping that taper with starting a preventative therapy. So if someone is using multiple doses of a triptan that's causing them to actually have more headaches, you have to taper off on the triptan use while starting usually a preventative therapy. Some people may even require a course of corticosteroids to help break the cycle. The big thing is when you recognize medication overuse headaches, to start tapering off on their medication, they need to know that their headaches are going to get worse or more severe for several days, maybe even weeks, before they can break the cycle. The patient we're going to be talking about as we go along is Leslie. She's a 25-year-old. She sought our help with her headaches. She reports that about 6 months ago, she started to develop throbbing bifrontal headaches that were associated with nausea and photophobia. There's no visual blurring, no aura beforehand, no double vision, slurred speech, numbness, weakness, no other neurological symptoms. Her headaches don't awaken her from sleep, and when she has these headaches, she has to sit in a dark room and try to sleep. After she wakes up, she usually feels better, but on some occasions the headaches persist. For the headaches, she used over-the-counter ibuprofen, which initially helped. At the start, the headaches occurred only once every few weeks and responded to ibuprofen. However, the headaches have progressed to the point where she has them every day. She's been taking the ibuprofen every day and even multiple times a day with no relief. More recently, she's had to miss work because of these headaches. Now we'll move on to talk about treatment of headaches. Complementary and alternative medicine use by headache sufferers is common. Survey studies have reported between a 50 and 80% rate of overall complementary and alternative use, but this includes things other than nutraceuticals such as chiropractic, acupuncture, massage, biofeedback, heat therapy, cold therapy, lots of different things people can do for headaches. In one survey, almost 27% of patients reported using some type of supplement in the last 12 months. Of course, they used 44 different supplements. There wasn't actually enough data on any individual supplement to say one was the most commonly used for headache. Treatment of headaches includes stopping an individual episode, and for people who have frequent headaches, there are preventive treatments. Acute treatment, of course, will depend on the type of headache. For most, we're talking about simple analgesics, or for a migraine, something like a triptan. There are not a lot of supplements used for acute headache treatment. This next slide sort of divides acute treatment up into prescription and OTC options and supplement options. As you can see, most headaches get treated with simple analgesics, caffeine, which works for both tension type and migraine, triptans, ergots, barbiturates, magnesium sulfate, a gram IV can abort severe cluster headaches, and oxygen is sometimes used, particularly for cluster headaches. Now, as far as supplements that are used for acute headache treatment, as I said, there's not a lot of them. Willow bark is one source of salicylates that's an option, but there's no data to say it's any more effective than using aspirin or acetaminophen or ibuprofen. Guarana and mate or yerba mate are two common natural sources of caffeine that you will find in many supplement combos that are targeted towards migraine. But these are just sources of caffeine. Honestly, no more effective than a strong cup of coffee. Capsaicin is one I wanted to spend a little bit more time on. Capsaicin, the stuff that makes hot peppers hot, is actually generating a lot of interest in treating primarily cluster headaches, but also some interest in migraines. For headaches, it's used as an intranasal spray or intranasal application of the cream. Capsaicin is thought to cause a desensitizing effect by relieving both peripheral and central pain by decreasing substance P. When applied to the nose, capsaicin is also thought to decrease central blood vessel neurotransmitters, cause vasodilation, and histamine or serotonin release. So that's the way it's thought to relieve headaches. So far, the evidence is promising, primarily for preventing and treating cluster headaches. Several trials have shown that using capsaicin intranasally might reduce the frequency of episodic or chronic cluster headache attacks. People have used both a suspension of capsaicin or the actual OTC cream, Zostrix. One note on each supplement that I go over, I'll talk about the ratings. And the ratings here are PE is possibly effective rating from natural database. Some of the other supplements also have a rating from the American Academy of Neurology in their headache treatment guidelines. One thing that's important here, if someone wants to try intranasal capsaicin, it needs to be done ipsilateral, which means on the same side as the headache. So it's applied to the nostril on the same side as the headache. 2 examples of intranasal capsaicin spray are Sinus Busters and Cynol M. These are both homeopathic products. And note the warning that is on the Sinus Busters. Upon initial use, you will experience a powerful sensation which lasts a few seconds. No kidding. It's not just a powerful sensation. It's intense initial pain when you put capsaicin, cream, or spray up your nose. Think about the worst place you've ever touched your hands after you've cut up hot peppers. So that's a big downside of the treatment, and people need to know that before they try it. So you get really intense initial pain. Patients can also sneeze. That causes their eyes to run, their nose to run. Most of the studies have used a topical local anesthetic before applying the capsaicin, and despite the local anesthetic, there was still significant pain for many patients. Now, we don't know do you have to have that pain? Because some people don't get pain with capsaicin topical cream. Now, I don't know about intranasal. Do you have to have that pain for it to work? And that may be true. Also, in addition to the homeopathic products, people can use, of course, the commercial creams like Zostrix. They apply it to the ipsilateral side, the side they typically have headaches, once a day till they no longer get the burning sensation. And the pain does seem to subside with multiple applications. And there probably is something to this use of capsaicin to disrupt headaches. Primarily, of course, cluster headaches is where it's mostly been studied. There's an investigational prescription formulation called Civamide or Capsaicin. It's a cis isomer of capsaicin that's being studied for cluster headaches, migraine headaches, trigeminal neuralgia up the nose, interesting, and a few other postherpetic neuralgia, a bunch of different things intranasally. I don't know if it'll ever make it to the market, but at least it's in trials for that now. Until it makes it to the market, these other things that are available are an option for people to try. Personally, I haven't managed to talk anyone into trying it for their cluster headaches. Once you talk to them about the pain with it, I haven't had anybody willing to try it. I do know of other people out there who've used it and found it effective. It's an option. Let's talk about preventing headaches. The majority of information is on preventing migraines. There's not a lot on other types, not a lot of studies out there that have been done. The studies that have been done on preventing tension type headache have not found anything that is more effective than placebo. Tricyclic antidepressants are an option for preventing tension-like headaches, but it really probably isn't any better than placebo, but people do sometimes try it. When should migraine prevention be considered? If people are having a lot of migraines, probably 3 or more per month, 2 or more days of debilitating migraines, more than 2 headaches a week. Just remember, if you're having more than 2 headaches a week and you're having to treat those, it's a risk factor for developing medication overuse headaches, which can transform episodic migraines into chronic migraines. And you can see the other criteria here. So really, if someone is debilitated by their migraines, they probably should consider some type of prevention. This next slide compares the first-line prescription agents and the supplements that have been studied for preventing migraines. First-line agents that are recommended by the American Academy of Neurology's guidelines for migraines are valproic acid, topiramate, metoprolol, propranolol. Those guidelines also cover Butterbur, Feverfew, Magnesium, Riboflavin, and coenzyme Q10 that we're going to talk about each of those in detail. Preventative agents can be important because they restore the effectiveness of acute medications. So if someone's finding that medications aren't working well or they have medication overuse headaches, preventative agents can restore the efficacy of acute medications. But a key point for educating patients is that preventative agents reduce migraine frequency. They don't make them totally go away. They're still going to have some headaches. It just decreases the frequency. But at least the headaches they do have are more likely to respond to the acute agents to a single dose, so they're not having to take multiple doses. Returning back to Leslie, because she was having medication overuse headaches and thus had developed daily chronic headaches, she was started on a preventative agent. She was started on propranolol, 80 milligrams extended release once a day. She's been keeping a headache diary. She limits her ibuprofen use, but it does work now for her headaches. After 3 months, her headache frequency has gone from daily to 2 times a week. So that's a great decrease, but she is still having about 8 headaches a month. She's also having an issue with dizziness and low blood pressure that might be related to the propranolol. She asked you today what you think about Butterbur or Feverfew. Would those be a better option for her? Well, let's talk about the evidence for those 2 agents before we can answer her question. Butterbur, or Petasites hybridus, gets an A rating in the American Academy of Neurology migraine guidelines and is rated possibly effective by natural database for migraine prophylaxis. Butterbur is so called because the huge rhubarb-like leaves were used to wrap around butter, supposedly, in the days before refrigerators. Butterbur is thought to have antispasmodic effects on smooth muscle and vascular walls. It may also exert anti-inflammatory effects by inhibiting leukotriene synthase. As far as efficacy, it does appear to reduce the frequency of migraine attacks. There have been 3 trials in adults and 2 in kids. An example from one of the trials, people went from 3.3 migraines per month to 1.7 at 12 weeks after being treated with Butterbur. The trials have seen a 48 to 60% reduction in migraine frequency. It may also reduce pain, intensity, and duration of the individual migraine episode. This next slide shows you data from one trial that compared a specific Butterbur extract standardized to 15% Petasitin and isopetasitin, and that's a brand name Petolex versus placebo. Importantly, and this applies to any migraine prophylaxis study, there is a significant placebo response. So if you give someone something and tell them it will reduce their frequency of migraines, it reduces the frequency of migraines about 30%. In this case, this study had a 28% reduction in migraine attack frequency with placebo. The 50 milligram twice a day dose of this extract was not statistically different from placebo, but the 75 milligram twice a day was, with a 48% reduction in frequency of migraine. This was a 16-week trial. Patients who want to try Butterbur should look for an extract standardized to 15% Petasitin and isopetasitin. The most effective dose in adults appears to be 75 milligrams twice a day. A smaller dose has been studied in kids. Butterbur extracts can contain pyrrolizidine alkaloids, which are carcinogenic, hepatotoxic, and nephrotoxic. So one really does want to avoid these. So in choosing a Butterbur supplement, they should look for one labeled pyrrolizidine alkaloid-free extracts. Pendilex is the one that has been studied, and it's also been shown to be alkaloid-free. You will find several different products out there that say they contain this particular extract. A couple examples are shown here on this slide. An adequate trial of Butterbur appears to be about 2 months, that it takes at least 2 months to see a reduction in migraine frequency. As long as someone is using an alkaloid-free product, the adverse effects of Butterbur seem to be fairly minor. Belching is the most common thing, and a lot of people complain of a grassy smelling, tasting burp. The only caution with this is allergy to ragweed and other members of the aster family, or ragweed, chrysanthemums, marigolds, daisies, those things. If someone's allergic to one of them, there's a possibility of a cross-reactivity. Feverfew is another natural product recommended for migraine prevention. It's probably more frequently recommended than Butterbur, but actually has less data. It is gets a B rating from the American Academy of Neurology and a possibly effective from natural database. Feverfew is also known as bachelor's buttons. It's also in the chrysanthemum aster family like Butterbur. We don't really know what the mechanism of action of Feverfew is. There are some studies that show it seems to inhibit COX-2, prostaglandin synthetase, and vascular smooth muscle contraction, which would all make you think it might work in migraine. There have been 6 positive and 3 negative studies with Feverfew. Meta-analysis by the Cochrane group, they found insufficient evidence to conclude whether Feverfew was superior to placebo. It does get, as I said, a B rating from American Academy of Neurology. The trials that were done with this agent all use different products. The positive trials primarily use dried powder leaf products versus alcohol extracts. This next graph shows you some data from one of the Feverfew trials. And this one's a little different from the previous type I showed you. This is average number of headaches per month. This was a trial in 170 people for 16 weeks. This used a specific extract of Feverfew called MIG-99. You can see a baseline. People in the trial had 4.76 headaches per month. When they were treated with a placebo for 16 weeks, they had 3.46 headaches per month. And then when they were treated with the MIG-99, 6.25 milligrams 3 times a day, they had 2.86 headaches a month. This was a decrease, but it wasn't a statistically significant decrease. Now, it seems almost like a clinically significant decrease. If you can go from almost 5 headaches a month down to 3 headaches a month, that might be something significant for an individual patient. The dose of Feverfew that has been used in studies is 50 to 300 milligrams twice a day. I can't really tell you what's the most effective dose that's with the powdered leaf products. With a specific extract, it seems that 6.25 milligrams 3 times a day was most effective. Unfortunately, I cannot find any products in the U.S. that have that specific extract, or at least label it that you can tell that that's the extract. What I recommend to patients is to seek out a product that says it's standardized to at least 0.2% parthenolide. The adverse effects of Feverfew, like Butterbur, are relatively minor: heartburn, nausea, diarrhea, constipation, abdominal pain and bloating, and mouth sores. Mouth sores is the one thing that sometimes people can get with Feverfew. The other important thing with Feverfew is there's something called post-Feverfew syndrome. That is where someone has taken Feverfew for a long time and they stop taking it. They can have withdrawal symptoms. Anxiety, headaches, insomnia, muscle and joint stiffness have been reported when people stopped taking Feverfew. So if somebody's going to stop it, it may be best to try to taper it off to avoid that syndrome. I can't tell you how long. Really no good information out there about how long someone has taken this when they might develop post-Feverfew syndrome. There is a potential for the cross-reactivity with things like ragweed, stuff in the aster or chrysanthemum family. It has been studied for up to 16 weeks. It appears that an adequate trial with Feverfew is probably 4 months, maybe 3 months, but I'd give it at least 4 months. The other caution with Feverfew, it is recommended to avoid it in pregnancy. And honestly, I kind of extend that also to Butterbur. So it's probably better not to use these during pregnancy because we really don't have a lot of information about using them during pregnancy or also during lactation. Testing of Butterbur and Feverfew products has not been done by consumer lab. There is one report out there at least of low or no parthenolide content in Canadian Feverfew products, but I can't find a listing of specific products. So at this point, the only thing I can recommend to you is to recommend products that label that they're standardized to a particular content, and that, at least with the Butterbur products, that they're alkaloid free. We have 3 other agents to talk about. The first of them is magnesium. Magnesium gets a B rating from the American Academy of Neurology and a possibly effective from Natural Database. Brain magnesium levels have been shown to be lower than usual in several studies of migraine sufferers. Magnesium's been studied for both prevention of migraines and treatment of acute headaches. It does work for acute headaches, but it seems to have to be IV dosed. It seems to lead to vasodilation, decreased platelet aggregation, and decreases in serotonin release. But the real question is, can taking exogenous supplements increase brain levels of magnesium? And we don't have a good way of measuring that. The efficacy of oral supplements for prevention has been studied in 4 trials, 3 of those in adults and 1 in kids. This next slide shows you information from some of those trials. For example, one trial used 600 milligrams of trimagnesium dicitrate for 12 weeks, saw a decrease in frequency of migraines, 41.6% compared with 15.8% in the placebo group. Another trial used 10 millimoles of magnesium twice a day for 12 weeks. And this was a negative trial that found that 28% of the people treated with magnesium versus 29% with a placebo had a 50% reduction in migraine frequency. And a 50% reduction is kind of that marker to say something's effective. If somebody has a 50% reduction in their frequency, then we usually say that is effective. So this trial saw magnesium supplements were equivalent to placebo. Another trial looked at magnesium oxide, 9 milligrams per kilogram per day, divided into 3 doses for 16 weeks in kids, and did see a decrease in frequency and severity, but it wasn't statistically significant. So we have several negative trials with magnesium, and that is one reason it only gets a B rating. There was one article in the Journal of Neural Transmission, and I give you the citation here. It's the last citation on the slide. They actually suggested in that article that everyone with migraine should be given a trial of magnesium. That there may be reasons that people with migraine lose magnesium excessively through the kidneys, or they don't absorb it well, and then it may be worth giving everybody a trial of magnesium. Now, the American Academy of Neurology doesn't support that approach, but again, it's something that doesn't lead to a lot of adverse effects. So it's not a risky thing to try in people. The dose that's been suggested for migraine prophylaxis is 300 milligrams of elemental magnesium twice a day. Of course, that dose can lead to some loose stools and diarrhea. Magnesium supplements need to be used with significant caution in people with kidney disease or heart disease. Those with kidney disease can't eliminate excess magnesium, so they can get hypermagnesium. High doses of magnesium can cause arrhythmias in people with heart disease. It's important to remember that a lot of medications can lead to magnesium depletion. Probably the worst offender is chronic use of proton pump inhibitors, and we have lots of those people out there. If you encounter someone with both migraines and long-term use of proton pump inhibitors, they're the people who might benefit from magnesium supplementation as a migraine prevention. Riboflavin is another supplement that's been studied in migraine. Again, gets a B and a PE rating. It's thought to improve mitochondrial energy reserve. There have been several trials, 4 adult trials. 3 of those were positive trials, but unfortunately only one of them was placebo-controlled. And they're giving very high doses of riboflavin, 400 milligrams a day. With that dose in the positive trials, you see about a 50% reduction in frequency. The 3 trials in kids have used doses from 50 to 400 milligrams a day. One of those trials was positive, but it was not placebo-controlled. And we know there's a significant placebo effect. Migraine prophylaxis trials really need to be placebo-controlled so you can see what the real effect of the intervention is. The dose that's been recommended for migraine prophylaxis of riboflavin is 400 milligrams a day. That is significantly above the recommended dietary intake, but this is a water-soluble vitamin, so we don't tend to get into trouble with excess doses. High doses can lead to diarrhea and polyuria, most common adverse effects. The other thing patients need to know is it can lead to bright yellow-orange urine, and that change in urine there can be interferences with multiple urinary laboratory tests. Coenzyme Q10 is another agent that has been used to improve mitochondrial energy reserve in preventing migraine headaches. It gets a C rating and a possibly effective rating from Natural Database. 3 trials, 1 in kids. Only one of those 3 trials was placebo-controlled. The 50% responder rate for attack frequency was 14% for placebo and 47.6% for CoQ10 in the 1 placebo-controlled trials. In the trial in kids, the kids with low serum CoQ10 levels were the ones who saw a response. What the dose that's been used is 100 milligrams 3 times a day, and it appears to take at least 3 months, maybe 4 months, to have an adequate trial of CoQ10. Now that we've reviewed all the natural options for preventing migraines, let's go back and look at Leslie again. Her question to us is, which would we recommend, Butterbur or Feverfew? If she's truly interested in using a supplement, I would suggest Butterbur because there's more data on it. It gets a higher rating. Since she's having side effects with propranolol, the dizziness and low blood pressure at 80 milligrams a day, you really can't go up on the dose of that. And she's still having 2 headaches a week. So she probably does need to try a different option. Now, prescription options for her, of course, are to look at topiramate or valproic acid. Now, she asked us only about Butterbur or Feverfew, but what about Riboflavin, Magnesium, CoQ10? There are other options, but they really don't have as much data supporting their efficacy as Butterbur or even Feverfew. She actually started on Butterbur, a product that contained Pendolax, 75 milligrams twice a day while tapering off the propranolol. After 2 months, her headache frequency is down to 3 per month. So she went from daily headaches to twice a week with propranolol, now to 3 a month with Butterbur. Now 3 a month, still not ideal, so we might want to look at changing to something else to see if something else is more effective. Another thing to consider might be to try adding magnesium supplementation in with this. There are no studies, though, that look at combination of any of these agents. She's not having any dizziness, but she does complain of lots of burping, but she's willing to live with that. One issue with Butterbur is there are no long-term studies. They don't go beyond 16 weeks. Some people have suggested that people stay on Butterbur for 4 to 6 months and then taper the dose down until their migraine frequency increases to see what the lowest dose is they can get away with without having a high rate of migraines. It really depends on how effective it is for people, whether I recommend they try tapering it off. Have not seen any issues with long-term use, but again, I haven't seen a lot of people who've used it for multiple years. This next slide just has some headache hygiene tips that are general things to help people try to prevent headaches and decrease the frequency themselves. It's like sleep disorders. There's a lot of hygiene things people can do to help decrease their frequency. They need to identify what their triggers are and avoid those triggers. So it may be skipping meals, it may be having red wine, it may be having an aged cheese, whatever it is that triggers their headaches. If they can identify those and avoid them, they can reduce their frequency. An important education point. Nothing works for prevention. None of these tips, none of the medications we've talked about work for prevention when patients are on a medication that's causing rebound headaches, those overuse headaches. A great way to identify if acute medications are working and what a person's triggers are for someone to keep a headache diary. There are examples online at the American Headache Society web address listed here that are daily, weekly, and monthly diaries that are written. There are also apps out there for people to track what their headache frequency is and what their triggers are. You can also use the diaries to track when somebody starts on one of these preventative therapies to see if it's actually working for them. The next slide just lists some resources if you want to learn more about all the different types of headaches and the way they are treated. So what's the bottom line? The bottom line for us is, can we help patients recognize when they have medication overuse headaches, help them recognize triggers, help them recognize that maybe they have chronic headaches and they need some kind of prophylactic therapy. As far as nutraceuticals go, Butterbur is the first choice for preventing migraines. Feverfew, Magnesium, Riboflavin, and CoQ10 are other options, but there's less data on their use. It's important that people with headaches, particularly chronic headaches, keep headache diaries to measure medication efficacy, identify triggers, and all those other reasons for using the diaries.